that show trabecular cracks and sclerosis and microcracks, and basically akin to a stress fracture of the microtrabecular bone. And this has been correlated with the degree of pain and the degree of arthritis radiographically. So this is called the S-core implant. It's a threaded, cannulated, fenestrated implant. It's got a chamber. There's a cutout on the side on this diagram to show that it's a bone-preserving type fracture implant, meaning that plug of bone is retained in the center, and it may serve as an attachment point for soft tissue augmentation. It's a set of implants that are in 1 millimeter increments, so they're especially designed for osteochondral fixation and fractures and osteochondritis dissecans. The idea is to give the surgeon versatility to be able to treat what they see. It's basically a cannulated screw insertion, so you have a guide wire and then a countersink to fully countersink the implant within the subchondral bone. And then there's a cannulated coring reamer that it's hard to see the flutes, but there are two cutting flutes on the side that create a circular osteotomy, so to speak, to vent that bone and retain the central bone plug. Hill-Sachs defects, there's non-anatomic and there's anatomic methods. Obviously here our goal is to try and preserve anatomy, or at least functional anatomy, as much as possible. These are some papers that have talked about osteochondral plug type procedures to address this. Is there a way we can do it over a guide wire or minimally invasive? Distal clavicle pain, treated typically with a resection, doesn't always relieve pain, especially in the setting of instability or trauma. It's obviously not anatomic. Is there a way we can preserve this joint and create some sort of functional repair? We can start the video. The first part of the video just shows a cadaveric representation of Hill-Sachs defect. This is our guide wire-based procedure where you can see the implant with the graft affixed to it and basically repairing the fracture defect. There's other iterations. This is a custom cut dermal matrix graft, or you can potentially use parallel implants to fix this. Our patient is a 24-year-old chiropractic student with failed conservative treatment, has distal clavicle osteochondrosis and pain and shoulder instability with this Hill-Sachs defect. We'll show some still images. This is a left shoulder looking from the posterior portal. You see the Hill-Sachs defect. And this is our guide wire planing reamer. We're looking through from the anterior superior portal posteriorly, inferiorly. That's after some of the prep work, and then we have the implant with the graft sutured to the top of it, and then a TAMP coming in to basically palpate and assess the level of repair, which we typically like to countersink the entire construct at least 0.5 millimeter with respect to the surrounding tissue. That's looking from the posterior portal. This is the video of the engaging Hill-Sachs defect, and this patient required a full pan-labral repair. This is on the back table. It's a 3 millimeter thick dermal matrix. We have this dermal punch that we typically oversize the graft by 2 to 3 millimeters with respect to the circumference of the implant. We put a slit in the center to allow the driver to come in, and then we use the driver as a sort of a stand that you'll see. And then we have these points of fixation. So we have a double-armed 3/0 braided suture that we're coming top to bottom through the graft and using these towels as a pin cushion, and we're capturing those needles on the undersurface of the chamber, typically 3 sets. You can custom cut the graft if you want, and then we have this, and then there's a knot pusher to put either interlocking half hitches or sliding locking knots. And then the driver, you can see, allows you to insert this. This is in a case where we're using the driver to sort of as a stand. My assistant's holding it. Obviously, we've already passed the sutures top to bottom, and then now we're tying these knots and fully seating them on the undersurface for secure fixation. And then, as I said before, it's it's a cannulated screw, so it's obviously a cannulated driver. And then we'll visualize that same patient from the posterior portal and show the insertion where you're basically able to dial in the level of repair. You see some nice healthy marrow contents coming up. The portal is, the posterior portal is an accessory portal that I didn't show the step. We typically use a spinal needle after you visualize the exact location of it, so you can get the right trajectory. When you're looking from posterior superior from the anterior superior portal, behind the biceps, you can kind of get an idea of the curvature of the humeral head, and you obviously don't want any graft remaining proud. And we want to have the entire construct countersunk with respect to the surrounding tissue. You can, if you change your mind, the driver can, if you remove the driver, you can reinsert it to adjust the level. It can be a little hard if you remove the guide wire, but that has been done. And then here's again, using it like a tamp to just kind of palpate, making sure it's countersunk enough, and then you can proceed with the rest of the arthroscopic labral, capsule labral repair. This is looking at it from the posterior portal. There's some different views. You can. This is the distal clavicle looking from the subacromial space. The same patient had a symptomatic distal clavicle. That's our coring, planing reamer for guide pin placement, and then prep of the site, removing the superficial disease bone and creating a nice bleeding bed. You see the guide wire in place there. So I'm in the posterior portal, and the guide pin and prep is done through a straight lateral portal. And you can see the driver is seating this into the distal clavicle. And again, we like to have this countersunk. That's a little bit further away view from the straight lateral. This is it coming in right underneath the acromion. It's a 7mm implant where my assistant's pushing down on the clavicle to sublux it, so to allow passage of this. And then you can see that there's flutes in the threads. If it's a self-tapping threaded implant, if there's significantly hard bone, you can use it as a tap, because the threads will clear if need be, or worst case scenario, you can size up or size down. And basically, we're seeing some nice marrow contents coming up through the repair site, and basically advance this into place for our reparative functional repair for the distal clavicle. And then we're using a tamp here also to palpate and ensure that we're nicely countersunk. And then we've done some biomechanics studies showing that at time zero, some recreation of joint forces with this construct. So we're able to mobilize the patients relatively quickly as the grafts are acting as an augment, being revascularized and undergoing remodeling. This is our patient. It's the left shoulder. He's approximately 8 weeks out. He's got excellent range of motion and recovered very quickly, and has continued to perform very well. We were able to do a second look a couple years out. He came back for his knee and was kind enough, and so we can see that there's some nice remodeling of the area. This is a CT arthrogram that shows nice implant stability and remodeling of the surface there, and the other is a knee. These are some of our clinical outcomes. Good, statistically significant improvement in PROs at 2 years, and excellent survivorship and patient satisfaction without any recurrent instabilities or failures in our small series. And these are some of the radiographs of what it looks like Again, it's a titanium hydroxyapatite coated implant. Thank you very much.